I'm here today with Professor John Camm, who is the British Heart Foundation Professor at St. George's University Hospital in London. And John, you were involved in the European Society of Cardiology Guidelines for atrial fibrillation. There are a lot of new changes from the prior guidelines, and I'd like to talk to you today about some of the thinking that went into the revision and the new European Society of Cardiology Guidelines for the management of atrial fibrillation. Please start off by talking a little bit about the changes that went into the guidelines in terms of selecting patients for maintenance of sinus rhythm for a rhythm control strategy.
Well, Ken, it's slightly different to the 2006 position. You'll remember in 2006 the guidelines stated that rate control was the first treatment strategy, and if the patient remained symptomatic, then rhythm control could be considered. In the 2010 ESC Guidelines, we still took this position, but recognized that there were some cases where a rhythm strategy was going to be a long-term objective, and it made no sense, therefore, in such patients to allow them to remain in atrial fibrillation and encourage atrial remodeling. So we slightly changed the position and said that in some cases, for example, young patients with relatively early onset atrial fibrillation in whom you were going to consider an ablation strategy, you should opt for a primary rhythm control management strategy and of course start in most cases with antiarrhythmic drug therapy.
Now, the guidelines, the ESC guidelines, has a nomogram, an algorithm that is very helpful to the clinician in terms of using patient information to select an appropriate antiarrhythmic drug. There's some very interesting differences between the ESC guidelines and the AHA-ACC guidelines, and I want to hear a little bit about your thoughts. So maybe start off with what the algorithm is, and then we can talk a little bit about what are some of the differences and what the thoughts were in Europe that led to these small differences.
Well, I think the first thing to say is that we chose to continue the algorithm which was originally developed for the previous set of guidelines. So we didn't make any major change there. The second thing, of course, is that we now have one additional antiarrhythmic drug, which is dronedarone, which has been extensively investigated for its antiarrhythmic action, and also in an outcomes trial it demonstrated that the use of this drug in patients with atrial fibrillation and cardiovascular risk, outcomes such as hospitalizations were significantly reduced. We explained all of this, of course, in the guidelines. So if we take the algorithm, it divides patients first into those who have minimal or no heart disease, and this includes hypertensive patients with no left ventricular hypertrophy. In these patients, we thought that dronedarone should be added to the routine and previous guideline so that dronedarone, flecainide, propafenone, and sotalol would be equal first choice antiarrhythmic drugs for that group of patients. As in previous guidelines, we left amiodarone to the drug of last resort, largely because of its substantial extra cardiac side effect profile. We then come to patients who have significant underlying heart disease, and these are divided into hypertensive patients with left ventricular hypertrophy, patients with coronary artery disease, and patients with heart failure. We could deal straight away with the patients with coronary artery disease because there we had only to consider including dronedarone, and the major decision was whether to place dronedarone ahead of amiodarone or equal with amiodarone or beyond amiodarone. If you think in terms of antiarrhythmic efficacy, then amiodarone is more effective. But if you agree that there is some added benefit to dronedarone, a feature not known to be associated with amiodarone, the reduction of hospitalizations, then it makes sense from that perspective to offer dronedarone first. So that's the position we place the drug in. Now, in patients with left ventricular hypertrophy due to hypertension, there is a difference between the guidelines. The Europeans included dronedarone as a choice of antiarrhythmic agent, whereas the American guideline update left the guideline with only amiodarone for that category of patients. Now, the information about amiodarone in that specific category of patients is very slim. The reason to exclude propafenone and flecainide is also an extrapolation from CAS data, and it's not strong evidence. Sotalol is also excluded from left ventricular hypertrophy patients on the basis really of some very basic research in isolated hearts and in myocytes, and there is very little clinical data to suggest that sotalol cannot be used in this group of patients. The major difficulty was the combination of sotalol and thiazide diuretics in hypertensive patients. So the previous guidelines suggested that amiodarone was the best choice. The question before the guideline committee in Europe was whether dronedarone should be offered to these patients, and there was no evidence that dronedarone was in any way contraindicated in that group, and therefore we left it as a choice in the left ventricular hypertrophy patients. The American guideline committee decided not to include it within that group. Interestingly, there's a Canadian guideline. They solved the problem by not identifying left ventricular hypertrophy as a different risk category.
And I was going to ask you, what data is there that it is a different risk category, and how do we tell the cardiologists in the community how to define that? Do they use echo? Do they look at EKG? Where is the cutoff?
Well, this was introduced in previous guidelines, and an arbitrary left ventricular wall thickness of 1.4 centimeters was chosen. It is arbitrary, and there isn't a lot of evidence that this is a different risk category, and I actually think that the Canadian guideline was probably the better approach. Then we should come to the patient with heart failure, and there are some differences here between the European, the American, and the Canadian approaches. First of all, we know that dronedarone should not be given to patients with unstable heart failure, particularly within the previous 4 weeks, and it should not be administered to class 4 NYHA patients with heart failure. Everyone, I think, is agreed on that because this was a group of patients who fared badly in the Andromeda trial when treated with dronedarone. So we excluded that group of patients. We also excluded patients with class 3 NYHA heart failure. That came about because of the extensive reviewing of the manuscript and a strong weight of opinion from reviewers and all of those involved in the guideline production that dronedarone, there had not been enough experience with class 3 patients, and so we also included them as patients who should not receive dronedarone. But we did agree that patients who had mild to moderate heart failure, NYHA 1 to 2, should have dronedarone, and we placed it, as in the rest of the guideline, ahead of amiodarone on the grounds that there was some potential added benefit from dronedarone. Our American colleagues chose specifically to state in a class 3 recommendation, as indeed we did, that dronedarone should not be given, in the case of the American guideline, to patients with unstable heart failure or with NYHA class 4 heart failure, and then was added especially if the left ventricular ejection fraction is less than 35%. Well, this is very similar to the European guideline, and I don't think it's very much different. Echocardiology is not widely available throughout the whole of the European arena, and we chose not to concentrate on that. Interestingly, the Canadians concentrated exclusively on left ventricular function and said that patients below an EF of 35% should not receive dronedarone. Now, the main difference, however, is that in the American guideline flowchart, under heart failure, you don't see a mention of dronedarone. But, on the other hand, it's only a formal recommendation stating that it shouldn't be given to the patients that I described a moment ago. So whether that was an oversight in not including it, or whether it was an intentional concept of not putting it in the flowchart, because pictures speak 1,000 words, right, so to speak. Right. If that could well have been an intentional concept, not to encourage people to use dronedarone in that setting.
In the European guidelines, what drugs can be used for patients who have moderate to severe heart failure?
Well, we only have amiodarone and dronedarone. We don't, of course, have dofetilide.
Why is that?
Simply because the drug was never taken to the European Medicines Agency. It was never formally approved by regulators in Europe, and therefore we simply don't have it.
Well, thank you very much, John. That was a beautiful explanation of the drug algorithm and what patients should get drugs, looking at the European Society of Cardiology guidelines, the Canadian guidelines, and the AHA ACC guidelines. Thank you, John.
My pleasure.